Good afternoon, everyone. This is the Florida Medical Directors Association Society for Post-acute and Long-Term Care Journal Club. The date is November 21st, 2019, and I am Dr. Diane Sanders-Cepeda. I am presenting this journal club, and we are going to actually look at something that we talked a bit about a few weeks ago, I think at the beginning of October, when I titled this, the focus of this, Revisiting Sepsis. If you attended the conference, you would know that we had a great presentation by Dr. Reyes and Dr. Auslander on sepsis. And we as a organization have been doing a lot of things around looking at what is the best care practice guidelines around treating sepsis, identifying sepsis, and managing it in the post-acute long-term care space, which has created a lot of conversation that we definitely want to get into and have a discussion about. So I want to start first by talking about the Sepsis 3 definitions. So when, just to level set with everybody, sepsis is the most expensive condition treated for all U.S. Insurers when we look at healthcare costs and utilization, and it's an area where there's a lot of miscoding and coding mistakes. But when you look at the dollar amount that we spend, it's about $24 billion spent on this for this condition alone, and that impact is over all the hospitals, 6.2% of all the costs for all the hospitals. And, it's a really some alarming numbers. So when we look at the Sepsis 3 definitions, which is from JAMA 2016, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. Septic shock is a subset of sepsis with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. Now, what you don't see is a definition any longer for severe sepsis. We don't see early sepsis, probable sepsis, or possible sepsis as definitions, although we see these terms used a lot in literature, not just the JAMDA, but in different publications, different presentations that you may have experienced. And what I love is when you see it on a hospital record as a discharge diagnosis. It was always fun being caught by some clinical documenter and coder for a query to diagnose and code someone as having early sepsis. And I say that because not only do I have a really crazy sense of humor, but when you look up these definitions, and if you were trying to code it, you'll notice that there's no definition in the coding language for early sepsis, probable sepsis, or possible sepsis. Everything goes back to sepsis unspecified. And if you went further into all of the definitions of sepsis, and we're trying to code this accurately, you'll see that we still don't have an early sepsis, probable sepsis, or possible sepsis, which makes us having this conversation very interesting, very unique, and I think it empowers us as leaders in the post-acute long-term care space to really say, okay, what are we talking about? That leads us into our first article. So can sepsis be detected in a nursing home prior to the need for hospital transfer? This is an article by Dr. Sloan, and it came out in 2018. And I want to start here because this is where a lot of our editorials and special articles are stemming from. So the purpose of this study was to identify if nursing home residents who are at risk or high risk to become septic can be identified early with simple screening tools. And the design, this was a retrospective study. It looked at 236 nursing home residents across 31 nursing facilities throughout the United States. They actually invited 35 to participate, 31 agreed. What they looked at too, when they looked at these residents, were 59 with discharge diagnoses of sepsis, and 179 had a non-sepsis discharge diagnosis. And they wanted to do designed their study to look at these individuals once they came back from this hospitalized setting. And the study measures included a time period. So they were looking at the 0 to 12 versus the 13 to 72 hours prior to hospitalization. All of this was by chart audits, and as I said, it was retrospective. So the nursing home documentation measures that they looked at were vital signs recorded, was there any notation about mental status change, and the medical provider visits within that 0 to 12 and 13 to 72 time periods. So those were hours. So the first 0 to 12 from when they identified that there was a change to the last 13 to 72 hours before that hospitalization. The study measures screening tools that they looked at were the SIRS criteria, so systemic inflammatory response syndrome, the QSOFA, the 3-100. Then they also included an oral temperature greater than 99 or oral temperature greater than 100.2. When we look at the characteristics of this population, they matched up pretty well. This was all, they've had these residents had a prior hospitalization, and they were looking at how many of them were diagnosed with sepsis versus, like I said, non-sepsis discharges, but came in on antibiotics nonetheless. They looked through their data, and they were able to get some interesting findings. So for that 13 to 72 hour prior to hospitalization, you can see that for the SIRS criteria, 6% met in that non-septic population versus the 10% who were identified as sepsis. For the 3-100, I thought that was interesting that we saw for the 13 to 72 hours, 16% met versus the 28%. But if you go over to the less than 12 hours, you'll see that in the 3-100, we were able to get some really good findings for that non-septic population and the septic population of meeting those criteria for possibly having sepsis. So the conclusions of the study was that the nursing homes need to have better systems to monitor nursing home residents with change of status, and they need to be able to deliver information to medical providers in real time. What they found was that there were a lot of times when vital signs weren't recorded at all, which I think is something that we can all relate to because we've seen that. There were also times when the medical provider wasn't either notified or even upon notification didn't come in and see that person within those first 12 hours or that 13 to 72 hour window. So that is why we need to do more thinking and around how do we identify this and can we detect and treat it. The takeaways for this study are really going to be captured with the next three papers that we're going to review. So the first paper that I pulled is actually a flashback from our last conversation early October. And this was a special article from JAMDA written by Dr. Millett, who has been on our calls before, and it was what is the role of nursing homes in surviving sepsis campaign. And just to provide an overview, this study or article addressed the expansive role of nursing homes in the surviving sepsis campaign, discussed the impact that sepsis has on the 30-day readmissions from nursing home, and looked at the disproportionate percentage of nursing home residents with a diagnosis of sepsis in emergency departments. And, you know, interestingly enough, when we look at nursing home residents, when they go out to the ER, they're 17 times more likely to be diagnosed with sepsis. And 4% of the ER visits among nursing home residents include a diagnosis of sepsis. So this is a major issue where it appears that our population are having more individuals go out for sepsis. The Surviving Sepsis campaign, they have a 1-hour bundle that includes measuring lactate levels, obtaining blood cultures, administering broad spectrum antibiotics and fluids and vasopressors if needed within that first hour of identification. When we look at this, it is interesting because we don't know, like, what can we do in our environment is always the question. And when we're looking through this, that's some of the things that we see that is brought forward when we look at the paper by Dr. Jump and the papers by Dr. Reyes and Dr. Auslander. So this is just an overview of the sepsis definitions and how they've evolved. We're now under the sepsis 3 definition, where we're talking about sepsis, as we stated, life-threatening organ dysfunction due to dysregulated host response to infection, versus septic shock, which is a subset of sepsis with many other issues that are ongoing, such as cellular metabolic abnormalities, that we've seen, and I'm sure many of us have seen these conditions, but just look at what we compare back to that 1991 definition, where we had severe sepsis, sepsis complicated by organ dysfunction, sepsis shock, sepsis-induced hypotension, more definitions from the 91 to the 2016. And then the tools that we have at our hand are the Sears criteria, 2 or more of the following, the Q-SOFA, which is 2 or more of the following, as you can see, and I'm not going to read through everything, but the 3-100 is temperature greater than 100, heart rate greater than 100, BP greater than, less than 100 actually. But these are tools that are available to us. And, when you're thinking about how do we apply this in the nursing facility, the question would be, do we have the staff? Do we have the right resources to actually do that? So what this paper really looked at is the uncertainty that remains around nursing home providers and staff being able to recognize possible sepsis, and the lack of effective nursing home sepsis screening tools that are designed and tailored just for this care setting. There's also, and if you could put yourself on mute if you're not speaking, there's also a need for intensive studies, and this article really addressed that. What we then get into is some editorials that were very interesting, and as I mentioned, Dr. Reyes and Dr. Auslander did a presentation, so some of this may sound very familiar. But the first paper is the early identification and management of sepsis in nursing facilities, both the challenges and opportunities. So once again, we go through the screening tools, and they really discuss Q-SOFA and the 3-100. And they looked at how do we utilize tools that we are already engaging in. As many of you know, Dr. Auslander and the Interact tool is one of the things that we are utilizing throughout many of our facilities. It really has changed the way the way we operate and guide through these changes in condition. So this editorial really reviewed, okay, what are the things that we need to consider? And they talked about thinking about our membership or our patient population a little bit different. We know we have issues with mental status changes, respiratory rate, hypotension, tachycardia, fever that come up when we're seeing somebody who is getting sicker, possibly septic, in those early stages. But we also need to consider the fact that there are medications that may impact if they can have a response where their heart rate could go up. There are medications that may already be driving their blood pressure down. What does it say about that, the physiology of aging as well, where our immune system doesn't make quite the same, work the same, and we may not have a fever when we are becoming sicker. We have other changes, physiological changes in the aging population that may lead to individuals having a respiratory rate that is elevated with many changes in condition. So thinking about that, the fact that there are physiological changes that happen as we're getting older, very non-specific changes, signs and symptoms that can be associated with an older person becoming septic, secondary to multiple comorbidities, cognitive impairment, the medications that they may be on and their numerous pharmaceutical interactions. It really behooves us to have a tool that can help us guide and identify if there's a change in condition. So this is from the study where they looked at applying the Interact and the stop and watch for early warning tools, initiating a change in condition, and using the SBAR communication tool, and really developing a pathway that once we're identifying these issues, to notify the clinician if we're suspecting infection or confirming infection, to initiate the treatment, and then making a decision on whether to transfer to the acute care setting or to treat and manage in the facility. Now, where that becomes interesting is people hear sepsis, they're like, oh, you can never treat that in the facility. You should never treat that in a facility. We need to move the person out. But what I really appreciate is the fact that the authors of this paper really took into consideration, okay, what happens to those individuals who have a do not hospitalize order? Or what happens when the family doesn't want that person moved or transferred? What needs to happen, and what do we do, and how do we initiate treatment for those individuals? And it gives us some recommendation for starting the management of sepsis in the facility, you know, looking at how to calculate a mean arterial pressure and what do we need to do with starting fluids and checking vitals and getting cultures and all of that, which leads us to some really interesting takeaways about early identification of changes in condition and how to utilize tools that we already have in our wheelhouse for the management and early identification of sepsis. And of course, the need for even more studies and more tools to help us identify and treat sepsis outside of the hospital setting, which leads us to our fourth and final paper, which is the post-acute and long-term care settings as first responders for the Surviving Sepsis campaign. This is by Dr. Jump and Dr. Susan Levy and Wade Saltzman. And they really took a perspective of what does it take for the post-acute long-term care providers and staff to become the first responders. So they looked at components of the Surviving Sepsis campaign, the Hour One bundle, and said what is feasible to do in the post-acute and long-term care setting. You know, and I'm sure this will generate some conversation in a minute about measuring lactate levels and getting blood cultures. But the administration of antibiotics, the rapid fluid resuscitation, what can we do inside of the nursing home? So can we get those blood cultures? Can we go ahead and start antibiotics? And can we begin IV hydration right there in the facility? You know, they said within the hours of recognizing sepsis, what are the early management for post-acute long-term care responders? And many of us who are practicing today have seen this, where we're getting those blood cultures, doing fluid resuscitation, ordering labs, getting the antibiotics started. And they even looked further, okay, if you're doing all that, what happens if we still need to arrange the hospital transfer? What do we need to be doing? Having those discussions with the family members? Have we already had these discussions with the clinical provider? Or do we have record of what happened and when was the change of condition? And how do we communicate back to that hospital team? So something that was interesting that they recommended was having a kit, a sepsis kit in the facility of things that we may need to have on hand and supplies that we may need to have readily available at our facilities. And this is a bit of an eye chart, but if you look in the paper, it's very interesting to see what they're recommending that we should always have, because there's some things that I know for the facilities that I have had the privilege of rounding in, we may always have on hand, and other things that you would have to make a request for. But it is interesting to think that we're thinking in this direction. And I would say that the takeaways from this paper include that clinicians and staffs are, for post-acute long-term care, are on the front lines to identify sepsis in the earliest phases and initiate management. But the other takeaway that we need to consider is, how do we get them prepared? So nursing facilities need to be prepared to initiate treatment early and need to adopt the protocols to identify sepsis early. You know, that is where a major takeaway and where we really need to think about and ask ourselves some questions on. So if we're looking at think about this practically, you know, I do, and others may disagree, but I do think that the post-acute long-term care clinicians and staff need to adopt methods to identify changes of condition early, not only for sepsis, but for everything. You know, that the earlier we identify any change in condition, the more likely we are to be able to treat that person in place. But what does it mean for post-acute long-term care to say that we've begun treatment for sepsis or are treating sepsis in our setting? Now, what's the liability around that? The number one question I've always been asked by providers out in the community is, well, if I'm treating this and I call it sepsis, I could get sued, because I didn't move them to the acute space. And if we're calling it that, should we go ahead and move it? So that's a fair question that we need to discuss. And the biggest question, I think, is how do we move forward as clinicians and as an organization who are caring for patients in the post-acute long-term care environment? And with that, I know we're very close to the top of the hour, but I'm going to open it up for discussion. So, whomever has any questions, because I really want us to think we need to talk more about what we are already doing and what we should be doing in this care setting.
Thank you, Dr. Sanders. That was a fascinating discussion. I think there are several things that come to mind thinking about this, because I look at the identification of sepsis, and I think that all those models are very high sensitivity and low specificity. So we have to sort of add some clinical judgment in addition to all the tools we have for identifying sepsis. I think they're by design very high sensitivity measures. That being said, I think that it does pose a challenge to be able to have the ability to respond to sepsis and treat initially. Just even getting IVs started could be a challenge in our setting. So I think that being prepared for this is something that we need to start talking about and start implementing.
Yeah, thank you, Dr. Novelli. I wholeheartedly agree. I think that if this is something, and it's something that we need to consider, that what do we need on hand in that facility to be able to initiate treatment for a multitude of conditions. If I want to place an IV in because I'm suspecting that somebody may have pneumonia, what do I need to do? And for those facilities that have Pyxis and in their facility, what do they have in their Pyxis machine? Or if they have a crash cart, do we have IV fluids in there? The greatest challenge that I've always had was the speed to getting labs, getting an IV placed, and getting imaging studies done in the facility. And I would think, and this is based off of my own experience in private practice, as well as my experience working with Optum, you have to know what the facility can do before you initiate orders. And you, as the clinician, should be looking at things proactively from before. So before I ever signed up that I was going to go into that nursing homes, gave them my CV and license, I wanted to know what they could do. And, it was very impractical according to many facilities, but I want to know if I can safely treat a patient here, if I was able to do certain things that I felt that we should be able to do. And I don't think it's unreasonable to ask facilities what they have, what capabilities they have. What I learned is when I went to work with Optum, this was part of their standard facility assessment. So I think that we need to start thinking about that a little bit more when we go into nursing homes, the same way we think about it when we go, if we were signing up to join the staff of a hospital. What can we do at this hospital that maybe another facility couldn't do? Any other thoughts or questions?
This is Maria Yanda. As a PA, my biggest problem is getting the primary on board with it, because they're usually are the ones that are afraid. So convincing them to be able to treat in place and, agree upon the labs, even when they see somebody sick, they want to send them right out. So I get pushed back for sure.
Yeah, and I think it's going to be interesting because, things are evolving in a way where we're going to see more facilities trying to possibly, I would say, in the near future, treat these conditions in place. There are facility chains that are doing those institutionalized special needs programs now, independent of an insurer, that they're becoming the insurer, and many facilities who are doing transitional skill plans where they are now their own insurer. And I can see this becoming a big issue as they start tapping into utilization. I don't know where the physicians are going to end up, because that's the thing that we need to start addressing within, for all post-acute long-term care clinical providers, whether you're the physician, a nurse practitioner, or PA. We need to have this conversation openly about what we are comfortable treating. And I think the greatest challenge is, being a leader in those facilities and really teaching them how to treat these conditions. I think that's something that we need to start thinking about a little bit differently. Once upon a time, we were servicing facilities about how to do things. And I don't know, given that most facilities now have their own education, I don't know if we're getting that education back to them. So I think that's a challenge, because making sure that someone feels comfortable treating a person is very hard. I can say that I feel comfortable treating somebody at a facility, but I've seen thousands of patients in nursing homes, and I've treated thousands of people in an acute care setting. So maybe my comfort level and experience level might be different than this other person's. So it is really hard. And I think that's why, and I'll get off the soapbox in a minute, but I think it's why we need to have some practice guidelines around this.
Well, I find another thing that's really helpful is if you have educated the family, or, the patient in some cases, and they are comfortable with it and they're confident and they see the benefit of treating in place. Sometimes it's not better, but the times that it is, that you can confidently say that you're going to be able to do this, and give the risks. It helps a lot, and having that documented is what usually, convinces the primary, the DOND to.
I totally agree, and understanding what the goals of care are for the family and the member, and having that all laid out very well prior to an urgent situation, irrespective of the urgent situation, is absolutely crucial. You're absolutely right, Maria.
Yeah, and I think that there's some, like I said, the climate is changing. We now have hospice units or hospice programs that are signing up contract beds in nursing facilities that can become a guaranteed inpatient bed. So instead of them moving that person into a hospital where it would cost that hospice more money to treat them if they were having an acute issue, they want to put them in a nursing home facility. And you now have to be able to say that you can do the IVs and all those other things that you may do for that person who is septic. And I thought that was very interesting to see that is now evolving. So I think that as we look at the developments that are happening in our space, we need to either train ourselves differently, think about things differently, set the conversation, figure out the guidelines that we need to adopt so that we can treat people appropriately in our facilities. Whether that means that we say, you know what, this is where we draw the line at and we need to move them out. We need to be able to speak with one voice on that, because from facility to facility, we're all doing something different. Any other comments?
That was absolutely excellent. Thank you so much.
Well, thank you all. Thank you, Dr. Novelli. Thank you, Maria, for speaking up. We will post the presentation to our website, and we thank you for letting us have this conversation once more.